Thank you very much, Dr. Ahmed. I was given the task of talking about achieving excellence in congenital cardiac surgery program. So I can say it in short. Go back, listen to the 4 speakers that we were today. We had outstanding presentation. This thoughtful approach is how you achieve excellence in pediatric cardiac surgery. Nevertheless, I prepared the talk, so let's shed some lights on some tools that would help in developing a program. I have 2 main objectives, is talking about the principles of total quality management and how we did it in Oman. I would like to start with saying there is no substitute to meticulous surgical technique. If we don't thrive as surgeons on a personal level to achieve excellence on day-to-day basis, then there is no system improvement project that would help you around. And this was embedded to us over and over and over in our training. And again, I would refer back to the outstanding talks that we've heard today, and you can see the impact of meticulous surgical technique and the thoughtful approach to surgical techniques in these, when it comes to outcomes. So these statistics had intrigued me for a long while. The estimated total medical errors annually worldwide is 43 million. Now, the estimated number of deaths due to medical errors are 2.6 million annually. This came from the WHO in 2019, was published in the BMJ. And when you look at the 3 main causes of death worldwide, we talk about cardiovascular disease, we talk about cancer, and we talk about respiratory disease. Well, when we plot these numbers, we can put medical errors as the 3rd. So again, that question comes to me and to us. Are we doing the same to medical errors as much as we are doing to cardiovascular disease? Are we not? So a few terminologies comes when we talk about this subject: quality improvement, quality assurance, and the principle of total quality management. So when we talk about quality assurance, it looks like quality assurance looks at the policy and standards at an individual level. The quality improvement looks at the process at a system level. Well, when we introduce the total quality management, is the assurance that a quality focus is maintained throughout every step of the healthcare delivery process. It came from the industry and has several and many aspects that is evolving and being applied more and more into healthcare. It is patient-focused. It's a continuous process improvement. It focuses on engaging people, managing relationships. It approaches an evidence-based approach to processes with an appropriate support from the leadership. It has 3 pillars, which is the process, the people, and the culture. When it comes to the process, again, in general, we have the tendency of being proactive rather than reactive in many aspects. Wait for the fire before trying to tackle the fire and putting a smoke detector, a simple device that could avoid us or prevent us from an obvious disaster. In medicine, we focus on mortalities and morbidity meetings. We focus on root cause analysis. We wait for the event to happen, and then we discuss. We discuss the near misses. We share these experiences with our colleagues. So this happened to me. I don't want it to happen to you. But that's the aftermath. While the reactive approach is putting the quality metrics, is looking at systematic data collection. It's a continuous monitoring process with implementation and assessment of all the efforts that are made throughout. The process has metrics, has data, and has projects. And when we look at the metrics, these should be patient-focused. It should be based on a predicted risk, and it has to be an ongoing metric that can be assessed throughout and not assessed as a snapshot. When it comes to data, it's important to have a good quality data with good data visualization to the whole team. Usually, the data visualization dashboards are restricted to the leadership team. But in the principle of total quality management, these data should be transparently shared with the team. We know the current status. There is nothing hidden about it. That's our current status. This is where we're going to reach, and this is how we're going to avoid it, how we're going to achieve it. And the processes or the projects are developed through the PDSA cycle. So you plan, you do, you assess what you have done, you act upon it, and it's a continuous process improvement. Few more principles, and then we'll go to the applications. So total quality management comes with roles and responsibilities that either can build you or kill you. It looks at 2 aspects. It looks at the front line So the frontliners require engagement. They require the buy-in. They require appropriate participation to achieve that is the goal that we desire. They need to be empowered, and they need to be involved in all the aspects. On the same time, for the leadership team has to be committed in engaging and supporting those frontliners. The leadership team has to commit to providing the appropriate resources required for the task that's given. And then comes the psychology of the team. We will fail at some point of time. And it's up to us and up to the leadership team whether to sink us down and hold us down the drain for our failures, or hold every member of the team crossing the bridge of the learning curve towards success. So, with that, how can we apply all this to a congenital cardiac surgery program? And we can apply it to any cardiac surgery program. So our journey with total quality management started at the National Heart Center in Oman in 2016. There were several issues, but then we had a meeting and we decided on focusing on several things. One was creating a national surgical database for our patients. And we were lucky being the only center in the country. We defined the quality metrics that we needed to focus on with an incremental 5-year plan. And then came to creating the team. And here came the challenge, a major challenge. There was no extra manpower for any QI projects. And we, as surgeons, QI projects or quality, anything comes to quality, is the least favorite. And the only solution to overcome this was changing the mindset of the people and engaging the people. We looked at the impact effort chart, and we chose. Basically, you can go for the high impact, low effort projects, which are the quick wins. We didn't have enough resources at that time to go for the major projects, which require high effort and high impact. So we focused on the low effort, high impact, and the low effort, low impact, accepting a sustained incremental change over the years. We knew it was going to take a long time, but hopefully it will be fruitful at the end of the day. Data collection was made with a focus on data quality. And I can't emphasize this any further. If you don't have good data quality, your outcomes are, or your data is as good as the data that's gathered. This was a sample slide that came in every department meeting. So we have a project, like a surgical database. There are specific responsible people required to do it with specific key results that are time-bound. Another example, for Fontan length of stay, we looked at it. So we assigned people. 2016, the task was reviewing all the patients that underwent Fontan in 2016 and come up with root cause analyses for the length of stays by 2017. And then an action plan and implementation in April 2017. And I remind you, this happened within the team. So the team who looked for who did the root cause analysis, were the team who made the recommendations, and were the team who were responsible for making these changes. So if you have a project here, and a project there, and another project here, you can see that the whole team is working on something and developing and pushing each other here. And it's given me a delight to see many of the team members attending here today, listening to this talk, and seeing our results over the last many years. We've built up on the QI projects over the years. So we had the SSI bundle, we had the fast track protocols, we had many projects. And we were able as well to convince the administration to give us the technologies that we need or resources that we need. 3D printing came from this. It was a requirement for excellence. And it's a standard of care in specific lesions nowadays. We acquired it, and that was a major game changer for us in the program. We started reporting our outcomes on a quarterly basis, focusing on the number of cases, types of procedures stratified, with the mortality stratified, and the morbidities, specific morbidities that we focused on. We tried to make it as simple as possible. And these quarterly reports were discussed openly across the whole team, with recommendations being generated. And again, a reminder here for all of us, focus on system improvement. It's hard in our culture, but the focus is on system improvement and not on finger pointing or criticizing people. We've created several campaigns and workshops. The campaigns helped us in achieving a focused objective assigned to a target group. So for example, initially we were it was difficult to convince people that we can fast-track specific number of pathologies and achieve lesser time in the ICU and lesser time in the hospital. So we created a fast-track protocol. We assigned 26 eligible patients for that. We've decided to do it in a short time frame by a specific group of people who believed on that. And then we shared the results with the team. So you can see here. So this fast-track protocol, for example, was done 100%, was achieved in 100% in 26 patients. 92% were extubated on table. These were straightforward procedures, yes, but this was not achieved before, with short ICU length of stay and short hospital length of stay. So then, when the team sees that and sees that they have done it themselves, this is not in a paper, this is not in North America or Europe, this is in your center, done by your own people, the team knows that they can do it and they can achieve further. And then the campaign's complexity increased, and these were specific objectives for every campaign. And that's how we developed the team. We also got the help from the STS congenital database update for outcome and quality, and then we benchmarked our cases in terms of outcomes. So we've selected 9 common procedures, and we benchmarked the procedures in terms of outcomes, and we also reported outcomes with risk stratification, which is the most recent approach now. We had KPIs, so key performance indicators, looking at several aspects of the patient management. So we had 20 KPIs in the unit, looking at ventilation time, ICU length of stay, inotropic usage, blood utilization, morbidity indicators, and these were reported on a dashboard, again on quarterly basis. So just looking at the dashboard, you know where you stand without basically have to this what gives you the close follow-up on your outcomes on day-to-day basis or even quarterly basis. So our outcomes, just give you one example. So when we benchmarked the cases in 2017, clearly we had an issue. So we had a good program that is up and running, but for certain pathologies, the mortality was high. And with applying the same methods that I've just talked about, I'll take you fast forward in time in 2023. We were able to improve on the majority of it and achieve even better outcomes than the STS for some pathologies. Yes, there are still other pathologies that needs more work, but it's a work in progress. When the mortality is halved by 50%, and the team knows that, and the team knows that they've done it themselves, not without any outsider help, then the process of improvement continues. Same goes for the risk stratification, same goes for the other morbidities like the length of stays. And then with time, other metrics and outcomes were developed. So on top of the morbidities that we were tracking earlier, we introduced the 1-year survival. Now we're looking at our residual lesion score for specific pathologies, and you can improve as you go. And after 8 years, we have more than 45 QI projects done in the department. Many of them are continuing with no extra staff. People are owning these projects. We have benchmark outcomes. We have a national congenital cardiac surgery database. We were able to introduce new technologies that were dream, and now they are the norm. In 2023, we started looking at our resource utilization benchmarking. 2024, we started developing policy changing quality research. Of course, research is another thing that we can talk about for long here, that was developed by many of the members of the team. One of them is Dr. Hamoud, who's one of my colleagues and the panelists in this talk today. And hopefully next year, we will be joining an international database for our surgical patients, inshallah. But to me, the biggest win was staff engagement. Numbers remain numbers, but it gives you no more pleasure than stepping into the hospital every day, seeing every single member of your team thriving towards excellence and working day and night toward achieving the best outcome for their patients. So with that, I'll conclude. Excellence can be achieved in any unit with deliberate practice, planned incremental change, and a focus on team building. And of course, as I said earlier, there is no substitute to meticulous surgical technique. Thank you very much.